Okay, morning. So we will be reviewing a case of headache that we had to deal with in Ward 5. And just to make sure that we hear what we...
You reach the low point when you have to throw scripture at people.
I hope we will use our ears and our eyes for the purpose. So the what was about headache. So our patient was a 27-year-old female HIV positive patient with unknown CD4 count that was off therapy of ARVs for 4 years. And she came with headache as a main complaint, sent from after attending a GP. So let's just do the Socrates. Dr. Muller, your software is different from mine.
Sorry.
No problem. So the Socrates, the site, it was headache, isn't it? And the onset was progressive. It was progressively worsening. It has been there for 3 weeks. And this headache has been happening on a daily basis. It was described as versatile, frontoparietal, and associated signs or symptoms were nausea, photo and phonophobia. And it was worsened when the patient was lying down. That is one of the characteristics that the patient volunteered, and the severity was graded just between 8 and 9. So it was assessed as a positional headache, isn't it? This was the assessment from the clinician that saw the patient. And even when we discuss, that is what he was presenting. If you were the person that discussed the patient with or if you had this patient with you, how significant it is to have that. Will it change the way that you manage your patient? Will it lead you to some differential? Because now we know the what, isn't it? It is the headache. So the second step will be, so what? What does it mean to us, isn't it? What does positional headache mean to us? What does positional characteristic mean for headache? Whenever we have a positional headache, and whenever we deal with headache, we know that we should look for the red flags. And the positional characteristic of headache is a red flag, is a danger sign for headache. It is not something that we take lightly. And under danger sign, why do we call it danger sign? Is that it is all about, is there anything growing in, or is it the pressure building up? And whenever it is positional, whenever we stress and we characterize the pain under assessment as positional headache, we need to be worried that there might be something serious going on. And that headache is more likely to be a secondary headache. Meaning, we need now to endeavor to find out what might be the source, cause of this headache and try to see or remember some of the specific features that may suggest what might be the cause behind. So just based on positional, there are 3 serious underlying disorders that can be in the background, which are a brain tumor, a raised intracranial pressure for any reason, and a intracranial hypotension. This clinical situation will give your patient positional headache. That is why they volunteered the information that it was worsening when they were lying down. That is the position and the effect of the position on the headache. Now, if it was a brain tumor and we had to dig further or elicit some answers from our patient, the position that matters is that whenever they change position of the body, the headache will tend to worsen, and particularly if they bend over. But when it comes to pressure, we say that the patient had nausea and so forth, being it raised intracranial pressure or decreased intracranial pressure. Unfortunately, you cannot rely on nausea and vomiting. You cannot rely on neck pain or stiffness. You cannot rely on photophobia. You cannot rely on disturbance. So both patient with raised intracranial pressure and patient with decreased intracranial pressure might have this symptom. So it is now worth to know exactly what is the positional kind that differentiate raised intracranial pressure from decreased intracranial pressure. Who can try? Is there somebody that can try? Yes.
I'm just going to add the sinusitis is one of them. If you think about it, with the bending forward and the pressure, symptoms that lead to headache.
But now that you are considering the possibility that it might be related to the pressure inside CSF wise, how do you make a determination that yes, there was nausea with our patient, yes, there was photophobia with our patient, so we cannot say it is raised or it is decreased, because both increase and the decrease gives you this manifestation. So this was the case of our patient. The pain was getting worse when the patient was lying down. So basically, to remember, and the opposite apply for hypotension in the brain. So to just remember that if the blood pressure, the CSF pressure is up, you go up, meeting your CSF pressure to get relief. And if your CSF blood pressure is down, you go down to get relief. You meet your CSF pressure to get relief. So at this stage, we should have been aware already, simply using the description of the pain, that we were dealing with a patient that was HIV positive without treatment, CD4 unknown, that came to us, that happened to also be female, 27-year-old, not on ARVs, with headache that are positional and suggestive of raised intracranial pressure. Because whatever we will be doing going forward, the workup will depend on it. And there will be do's and don'ts that will be guided by this determination. But if we don't appreciate at this stage that we might be dealing with raised intracranial pressure, we might do things that might lead to disaster. So it's not, when we talk about headache, so it's not only now we've remembered that positional headache is a red flag, but there are many other red flags there. And I hope that this face will not give you a headache. You know who is that one? It's Snoop Dogg. And it's because Snoop 10 are red flag that we needed to remember. So it was easy. If the person that dealt with the patient once, and we had a lot of presentation on headache here, and we reminded one another from time to time. It used to be Snoop only. It has been upgraded to Snoop 10. So the first, if you have headache with systematic symptoms that include fever, it is a red flag. If you have headache with a history of cancer, it is a red flag. If you have headache with neurologic deficit, it is a red flag. If you have headache of sudden onset or abrupt onset, it is a red flag. Same apply to when elderly get a headache, it is a red flag. Same apply to somebody that might have got chronic headache, but when the pattern change, it is a red flag. Or if there is a new onset or a recent onset of new headache like our patient, it is a red flag. On top of having a positional headache, when it is precipitated by sneezing, coughing, or exercise, when you have access to fundoscopy and you get papillary edema, it is a red flag. Same apply to when the headache is progressive. When you deal, remember our patient was a 27 female patient, so a pregnancy test should have been done, because if you start having headache while you are pregnant or in a period, it should be a red flag because it can be preeclampsia. And if your patient eye is painful with autonomic feature, it is a red flag. Same apply to after trauma. When they develop headache, it is a red flag. Patient with HIV, when they come with headache, you need to be worried that something sinister might be going on. Same apply to people that abuses analgesics. So just an opportunity for us not only to learn or to remember positional characteristic as a red flag, but to know that there is more than the positional whenever we deal with headache. Yes, 90% of headache will be primary, but 10% that are secondary. If we misdiagnose them, we might end up with a disaster. So this applied to our patient. It was positional. It was recent onset. It was just 3 weeks. It has been progressive in nature, and our patient is a known person living with HIV. And also under recent onset of new headache, in the background, there is always a possibility that there might be a serious disorder going on. So now, then what? So we know that there was a patient with headache that happened to be HIV positive, not on treatment, unknown CD4 count, who is a female, overweight, with a positional headache that happened to meet the characteristics of positional with raised intracranial pressure. Now we know that in the background, there might be a serious condition. then what? Let us remember this, because what happened is that considering imaging for this patient was dismissed. Because my interaction with the clinician that dealt with the patient, we were all excited and said, okay, we need to start with, and so, oopsie, the LP is already done. I was advised against sending the patient for brain CT, although it was in his plan and he chose to cancel the CT brain. Whenever we have positional, it is all, whatever we will do, the then what is about what do we choose as evaluation and what will be ultimately the treatment that will be offered to our patient. And we are looking for a serious condition that might be HIV related or HIV unrelated, isn't it? With increased intracranial pressure. But we chose the shortest road to meningitis, meaning we LP the patient.
Why is that wrong?
There
was no indications for raised infiltration of obstruction of edema or photophobia.
So if a fundoscopy was not done, how do we know that there is no papilla edema? It was not done neither. That's why it is the shortest road to meningitis. If those determination, if papilla edema was done through fundoscopy, determined to be there or not there through fundoscopy, it's fine. If ultrasound was done, it's fine. But in the absence, that becomes a little bit risky for the patient. So we went for that, maybe based on the fact that the patient was HIV positive, CD4 unknown, and we had already some of the things that are rare, even they happen to be in our patient. We went maybe for meningitis, most probably meningitis that would have been cryptococcal, because it is the commonest meningitis in our setting, isn't it? When we compare to other, taking the viral out, we went for the LP because it requires confirmation. When you think of cryptococcal meningitis, ultimately you need to confirm by doing a LP, but they are mandated in this clinical situation that we should go through either fundoscopy or ultrasound or brain CT for the patient safety, because everything that we do, it is for the patient safety. Because I don't think, even if this patient gave us consent, did we get an informed consent with that patient that might agree that, you know what, you might be 3 out of 100 people that can cone when we do this LP, and if you cone, it is 50-50 that you might make it, because that is the reality. So the mandate is that whenever, that's why we reminded one another about this red flag. That's how we learn about the reason why we should be learning about this red flag and remember about it is that the recommendation is that whenever you think of this, in the context of secondary headache, ideally, you should get a brain imaging done. And it is not even, it is should prompt. Because the major causes, as we say, can be intracranial mass, can be cerebral edema, can be increased production, can be decreased absorption through cryptococcal meningitis or even bacterial meningitis. You can have obstructive hydrocephalus, obstruction of venous flow, or you can have idiopathic intracranial hypertension. Those are the things that we should think of. And some of these causes, if they're and overlooked, and we put a needle, we might end up in trouble. And our patient might can demise or might end up in ICU. So, again, this because linked to recent onset, those are the causes also that comes into consideration. So there is really need for us to be safe, to be considerate about the risk that we put ourselves in as a litigation if something happened to go wrong, but also the risk that we might expose our patient to. This again are the recommendation. And even when we went for cryptococcal meningitis, we should have been mindful of this fact. Yes, ultimately, when you confirm that there is cryptococcal meningitis with raised intracranial pressure, part of the management is, beside antifungal therapy, aggressive management of that raised intracranial pressure. But you should first make sure that there was nothing sinister that would have led. Yes, you can do a CT. A normal CT is not a guarantee that somebody will not call, but you have done your best. You are covered if something happened. Can we hide behind the fact that, let's say, for example, there is no CT? Are we covered? And say, let us just do that. Can we choose not to do it? And if we chose not to do it, does it mean there was no indication of those tests? So we do this primarily to diagnose, but we also do the CT for safety. And there is an issue about, will it be urgent or will it be emergent? Whenever there is a serious life-threatening headache that is considered, it becomes an emergency to have access to that CT. And again, as we say, if fundoscopy was done and there was papilledema, for example, in our patient case, because our patient didn't have any focal neurologic deficit, still, it would have been an emergent indication for a brain CT in this particular patient. And our patient had repeated episode of nausea with a headache that was meeting the criteria for increased intracranial pressure. But even if there was not life-threatening condition, but serious condition, still our patient would have qualified for a brain CT. So what else, as we say, we do the CT for safety. Because we will be subjecting our patient to a lumbar puncture, isn't it? Because we consider the possibility of meningitis. But for us to do a lumbar puncture, we know that there are clinical situations where a CT is recommended prior as proceeding with a lumbar puncture. And by doing also that lumbar puncture, if we made an assessment from the get-go that our patient had a raised intracranial pressure because of the way that they described the pain that was worsening when they were lying down, not only would have done the lumbar puncture to get the CSF4 analysis, but would have also used that opportunity to measure the patient opening pressure. Because the recommendation today is that every single lumbar puncture ideally should be coupled with measuring the CSF opening pressure. So, and this is a statement from that paper to mean that whenever we do a LP and we didn't measure the opening pressure, it is an incomplete procedure. It is substandard way of dealing with our patient. And we know one of the reasons why we don't do it is because we don't have manometers, isn't it? But they are common validated practices now for resource limited setting like ours, is that we can use the intravenous giving set. It is validated, it has been studied. It is not something that you just do out of the blue without any backup. It is something that has been studied. And what you just needed to remember, it does underestimate the people that studied and compared the blood pressure that you read from here and from the manometer. These tend to underestimate. So a CSF opening pressure of 19 here is the equivalent of 25 days. So basically, if you take the cutoff of 25 for you to decide by the book that the patient has raised opening pressure, you don't wait for 25 on the IV giving set. By 1920, you consider your patient as having a raised intracranial pressure, while on the manometer, you will wait for the 25 for you to make that determination. So it has been validated for that purpose. So when you do it with the knowledge that it does underestimate. But there is a new way also of inferring the blood, the opening pressure is by counting the drops, the flow rate of CSF per minute. It has been found, again, it has been studied and published in good journal and recommended by many bodies that 40 drops per minute or more is a value to be considered for high opening pressure. So our patient, not only we should have written positional, but we should have counted so that we documented that it was positional, but there was not raised intracranial pressure, even if you were alone, because this is easy to do when you are alone, because when you use the IV, you need somebody to hold for you. And it does have you need to use, unfortunately, in our setting now, where we don't have the black needle, we cannot use the drops. So that is another logistic. Not only they made life difficult for us by not providing us with the manometer, now because we only have the oranges and the brown, we cannot even count the drop. So you need somebody to hold for you and determine, which takes longer. So again, in the then what, because we made the determination as we were discussing, and we have this toy available to us. This patient was cooperative. We could have taken this patient to the room and determine if there was papillary edema, because condition that raises intracranial pressure may lead to papillary edema. Although the absence of papillary edema, like a normal CT, doesn't mean no raise, but you would have done it, you'd have documented it. Even if there is a complication, you did everything by the book and with in mind the safety of your patient. Again, still, we also have an ultrasound. We could have measured the optic nerve diameter. So we had a lot of things at our disposal, but we didn't want to just see that positional was the equivalent of increased intracranial pressure, and we didn't want to see the recommendation that for the patient safety, you rather do these studies, one of them to document that it was safe or not safe for the patient to do to get a LP done at that stage. So, like we were saying again, every time there is a headache and papillary edema, if we did the fundoscopy, there should be an urgent imaging. Even if at the end of the day, it will not show danger sign on the CT, but you would have done things properly. Again, when we read things, they will tell us these are clinical situations where ideally you should get a CT done before you get a LP done on your patient. We've spoken about this. Yes, it can be normal. It doesn't exclude. Yes, when two people review a particular CT, they might not agree. But that is the tool that we have for now. And we should be, if we have access to it, why not do it? And if we choose not to do it, then let us obtain a real informed consent and see if the patient will agree. So now, we've been talking about the CT. When we send the patient for a CT, what do we look for? Because it's nice to say, now we know that it was a positional. Now we know that it was secondary and there was a possibility of a serious cause. Now we know that we should have done a CT or would have done a fundoscopy or done an ultrasound. But if you had access to a CT, what are you looking for to be content that the risk might be not as high as you thought, or it could be if you didn't do a CT? Which are the changes that you need to look for? What do we usually look for when we've been ordering CTs for our patient prior LPs, isn't it?
I look for that report.
They don't give you a report for the CT.
So you will look at loss of gray white differentiation. You will look at mass effect midline of the transverse images. You will look at herniation of your tonsils on your coronal ridges. You will look for reduction in your sodium fissure or your clarity of your sulci guiding, which are all features that you might find.
So I brought this up because we usually focus on the midline shift. It's not enough. Yes, that is spectacular. And we look for mass lesion. It is easy to, but that is a space occupying lesion, but this is not a contraindication because the midline is straight. It is when you have something like that. This we easily can pick up that there is a midline shift, but it is more than the midline shift. As we were saying, look for signs that will be suggestive of cerebral edema and signs that might suggest hydrocephalus. So edema, like we say, loss of gray-white differentiation, compress lateral ventricle, and effaced basilar cistern. Those are the things that we need now to learn, because you've ordered the CT, you looked for the mid-shift, the midline shift only, you overlooked this, you put a needle, your patient called, somebody pick up the CT, you're in trouble. Hydrocephalus, again, you have the ventricle, the third and the lateral will be, and the cistern and the sulci will be gone. Same apply again for cerebral edema, that your sulci are also effaced. So those are the things that we need to remind one another. And fortunately or unfortunately, our patient didn't vomit. Our patient had only nausea, but in positional headache, they will tell you, or headache that may be considered to have raised intracranial pressure. They say, this is a self-declaration of brain shift. When you have a patient that has a decreased level of consciousness, or has a headache and is vomiting, has a headache with neck stiffness, focal neurology, bradycardia, or that, those are the signs that that's brain shift is waving at you. You need to be mindful of that. That is the reason why we brought up this talk, because what is the fuss? The fuss is about there is a possibility when you deal with a positional headache that is having raised intracranial pressure in the background, you have this as a risk, and this is a serious complication. And because we talk about it, I hope we all know how to recognize it, because it's not only nice to talk about it, but whenever it happens, can we recognize it? Those are some of the characteristics that will make you, whenever you do a LP and this happens, it means your patient is herniated. And this becomes an emergency. And remember, it can lead to death. As we say, 1 in 2 patients that herniate might not make it. So we were happy the patient left our rooms walking, but should we have been really reassured? Because I would say, no, I did it, but the patient didn't call. half of them can take up to 12 hours to occur. So they might have left your rooms walking, but you don't know what will happen out there. This is in one series. This is in another series. So it can happen. It's not because the patient left the room alive, walking, that this was avoided. And it is not also because we know that when there is raised intracranial pressure in cryptococcal meningitis, we need LPs as therapy, that we will just disregard the safety of going through imaging or through fundoscopy or through sonography for the sake of safety. This is just a quote from this article in 2013. I will just read it. We are done. Raised intracranial pressure is common, being it in surgery or in medicine. Symptoms, signs, and management should be front of mind of these treating physicians that we are. So when we saw that positional headache that was worsening with recumbency, we should have rang the bell to say there is a possibility of raised intracranial pressure here. And let's go through those measures before we do a LP on our patient. Again, there is only one lucky look. Let us not shoot our degrees. Thank you very much.